as our speaker today. Dr. Barbaro is a pediatric critical care physician, health services researcher, and implementation scientist. His research seeks to improve the short and long-term outcomes for children requiring ECMO. Dr. Barbaro is currently leading the NIH-funded study called ASCEND, which aims to characterize the one-year outcomes of ECMO-supported children and aims to address the question of if and when ECMO should be initiated in children with severe lung injury, in a type of severe lung injury called pediatric acute respiratory distress syndrome. He is a member of the Extracorporeal Life Support Organization Board of Directors and is co-chair of Pedi-ECMO. Thank you, Dr. Barbaro, for coming.
Thanks so much. And it's, wonderful to be here and talk with you about ECMO, which I think of really as just a big dose of critical illness. And so as such, I think it provides a nice window or microcosm of critical care that is a lens that amplifies both challenges and opportunities within the space. And so as was already kind of said, some of my, in terms of disclosures, I sit on ELSO as well as Pedi-ECMO and have some funding from the NIH in the space. In terms of just briefly where I'm from and how I got here, I grew up in a military town, Fayetteville, North Carolina, where we were stationed because my dad at the time was at Fort Bragg, North Carolina. Then spent the next decade at UNC, where I did my undergraduate medical school and residency program before coming here to the University of Michigan to do health services research as well as pediatric critical care. But mostly I'm a dad. These are my 6 kids. So this is my twin sons who are 16, Dane and Andrew. My daughter, May, who is 14, Nora, who is 11, my 3-year-old Grace, and my 2-year-old Anne. I'm also, though, of course, an intensivist and health services researcher. And as one trained at the University of Michigan, I elected to organize this within the Donabedian framework of structure, process, and outcomes. And so I'll start first, just though, for anyone who's less familiar with ECMO or thinks about it slightly less than I do, just an overview of what the technology is and what it's meant for. And so it's a life support technology that really relies on a blood pump to remove blood from the body and push it across an artificial lung that works very much the same way that our own lung does. So that just there's an artificial supply of gas as opposed to what we breathe in that then sends through these little tubules, microtubules, and then the gas diffuses across a barrier and then onboards onto the red cells and offboards CO2, which is then actually exhaled out of the same artificial lung, just like your lung does. It then returns oxygenated to the patient, either through a large dual lumen cannula, mostly in children, that sits in one of the big veins of the neck, or through both 2 single lumen cannulas, one in the vein and one in the artery of the neck. Importantly, that's generally the carotid artery, the one that is bringing the blood flow to the brain and thus potentially putting the patient at risk for some complications. Like critical care, ECMO is quite heterogeneous. I mean that in terms of the patients that we care for, as I allude to on the previous slide, that can be in lung failure or heart failure, even children who are experiencing cardiac arrest that's not able to be reversed. It can be in our practice. I'll talk about this later, but as well, but in terms of the way we anticoagulate patients, but also uniquely maybe in medicine, it's different in terms of the device. So because within children, and I'll talk about this later as well, that many of the devices that we use aren't cleared, we actually end up adapting the technology. And so this is a common device called a CardioHelp. It's an integrated pump in a lung. It's about the size of a shoebox. It comes with a tubing set, and you just kind of connect it onto the cannulas. And Dr. Bartlett likes to say you can kick it under the bed. These are more of the systems that most pediatric hospitals will use, where they're kind of buying an individual blood pump, they're buying a membrane lung, and they're putting it together with a custom-built tubing set that has all kinds of connectors and things in there that are potential areas for complications. But as a person who thinks about ECMO a lot, I get an opportunity both at the bedside as well as in partnership with folks both locally and around the world to think about children. And one of those children was this 14-month-old who I'll call Jane, presented in septic shock, secondary to RSV, with a complicating bacterial infection, MRSA, that resulted in an acute respiratory failure, pediatric ARDS, with bilateral necrotizing pneumonia, or actually dying of the lung tissue as a consequence of the infection. She progressed to a point where her heart and lung was no longer able to be supported with our conventional strategies, and so she was placed on veno-arterial ECMO. And so her concerned family, like all concerned families that come into our ICU, really want to know what all this means for their child. And so I'll start by talking a little bit about some of the outcomes and what we do understand in terms of what that looks like in terms of ECMO as well as within critical illness presently. And so our sickest kids receive ECMO support, and they're really at some of the highest risk. And so, but this is extremely rare. So there's 75 million kids in the US right now. About 0.5% of them, and this is probably a robust estimate, receive critical care within our hospital systems, and about a 0.25% of those receive ECMO. But the mortality rates are vastly different. And so 2.5% of PICU admissions might die, whereas over 40% of children who are supported on ECMO are likely to die. These kids are sick and they have adverse events that are really on par with the adverse events we see with children who have a cardiac arrest outside of the hospital and present after that to EMS services. So in the population of 1,000 patients, 60% had a severe adverse event, whereas 30% had 2 or more. And the highest frequency was in the smallest children, our neonates. And that's similar to what we saw in ECMO in a prospective observational trial of 514 children were enrolled. They saw bleeding complications in 70% and clotting complications in 40%, with severe complications such as intracranial hemorrhage happening quite frequently as well. And so just elucidating that same point that this is happening more frequently in those smaller kids, this is just failure of the device of the cannula, 13% in neonates and children versus 5% in adults. When we think of the circuit itself failing, that's 30% or 15% versus 2% in adults. And that intracranial hemorrhage rate that we were talking about before occurring in 23% of neonates, 16% of children, and 3% of adults. But for most of our families, they think beyond the ICU as well. And so as we come in and we're supported on lots of technology, our families want to know what happens in terms of the health-related quality of life and functional status to their kids. They want to know what happens in terms of organ dysfunction, duration, and post-hospital development. And these are concepts that have been organized into an idea called post-intensive care syndrome, which Dr. Carlton has spoken to in the past as well, but has really been organized within kind of 4 domains of physical, cognitive, emotional, and as well as social health. While we're still really at the infancy, these are really only been characterized within the last decade. There is ongoing science here, locally led by Dr. Carlton, to better understand what this means in the space of pediatric intensive care syndrome. What we do know already, though, is that about 5% of children who are admitted to the PICU are going to be discharged with a new morbidity. About 23% of those with pediatric ARDS will, and 6 months after, a lot of that will still be persistent. Within ECMO, those numbers are just higher, and so 40% have that change. And when we look at really kind of severe changes in that FSS, it's functioning, it's 16%. And 40% of those that have pediatric ARDS also have a new morbidity, though this population understanding is from just handfuls of patients. So this is from a single center study that looked at 12 patients that were on ARDS. So an area where we really need to have better understanding. When we think about health-related quality of life, there have been a couple of larger studies that are in the setting of larger clinical trials. One was called Restore-COG and another was called PEPINIC. And both of those showed really that while there was some changes in health-related quality of life, on average, that change was quite small. When we look, though, at proportions of patients that had a standard deviation decrease, meaning something that looked like a patient who was newly diagnosed with cancer and undergoing chemotherapy, that about 1/3 of patients with acute respiratory failure had that decline of 1 standard deviation. That's similar to what we saw in ECMO, but this population, once again, is quite small. This is from 16 patients from a single center study. So really just starting to scratch the surface of understanding what all of this means. This is a Restore population of about 500 followed up patients. This is, like I said, 16 patients, and this is 9,000 patients. And so when that family asked us, what does this mean for ECMO for my child, Jane, it means a higher mortality. It means higher adverse event rates. It means post-intensive care syndrome likely at worse in terms of physical health. We really need more research in terms of the cognitive, mental, and social health. And I sense that there's not really as much of a dose effect, though, in terms of the health-related quality of life of children. And so building on our understanding, we hope to add through ASCEND, as was alluded earlier in the study, which is a prospective study that takes advantage of some of the existing frameworks. So we use the ELSO registry to kind of collect information on patients as they are receiving usual care ECMO, as well as we take advantage of an ongoing clinical trial called PROSPECT, which seeks to randomize children into various different strategies of mechanical ventilatory support, but withholds ECMO until a space that's a little bit further down the path than we typically see in usual ECMO strategies. And that study is called PROSPECT. And then ASCEND adds on to that a long-term follow-up that's done through both phone calls as well as text messages and then conventional and electronic mail services to be able to collect surveys at 1, 3, 6, and 12 months beyond ECMO. Our goal is to really better understand just what that trajectory and one-year functional status and health-related quality of life looks like in children who are receiving ECMO under usual circumstances, and then to compare those outcomes both in terms of 90-day mortality and one-year functional status to those cares that are being received in similarly ill patients in PROSPECT. And the way that we do this is really by integrating that medical health record information is already being collected within ELSO, supplementing it with an ASCEND addendum that's embedded within the registry, collecting some additional information in terms of quality of life surveys and contact information that are separately held on different servers for the protection of patients, and then following those folks up after their discharge centrally here at the University of Michigan. And actually, Lee Campus, who just walked into the VA, is one of the folks helping us work on that as well. And so here we have a couple of different cohorts that help us to look at that natural history aim, which is just those 550 patients that we aim to enroll in ASCEND. And then among those that are enrolled in PROSPECT, we'll hopefully match up similarly ill patients to look at short-term comparative outcomes in terms of mortality, as well as longer-term comparative outcomes in terms of their health-related quality of life. We look to do this by both having propensity scores that match a hospital and a patient level propensity score. The hospital level seeking to find hospitals that are similar in their likelihood to have participated in PROSPECT, and those patient level propensity scores aiming to model children's likelihood to receive ECMO under usual care circumstances. And then the strategy of matching will seek to prioritize variables that are likely really important in terms of the delivery of care, as well as in terms of configurations that maximize our sample. Progress is going well. We have 325 patients enrolled across 81 sites in 4 continents with a 12-month follow-up rate at 88% and roughly 2 more years to go in terms of data collection. I'm also really excited about this work that Dr. Erica Andrus from our critical care group has added on through a bioethics supplement, which seeks to better understand through qualitative research what are some of the factors that clinicians are using when they inform recommendations for a family to remove a patient from ECMO. Also, they seek to she seeks to better understand kind of current practice patterns and practice variation and approaches by interviewing those healthcare providers as well as families. So why don't we understand what's going on better? I think there's a lot of reasons for that, but part of it is the structure of both our evidence generation system as well as our device clearance approach. And so this work
what is device clearance?
Device clearance, thanks, means so when you use a device, any medical device in the US, it is cleared by the FDA or it is used off-label and cleared for a different indication. And so thanks for asking. But like critical care, ECMO is growing, but it's really quite rare. And so the median center volume amongst those centers that are performing ECMO was 12 in 2009, but now has declined to 7 or 8 in 2022, even despite the fact that the overall volume is increasing. In adults, a reverse pattern has been seen. Or in 2009, when this is when the H1N1 pandemic occurred, it was 4. In the COVID pandemic, kind of at the height, it was 20, and now is reduced down to about 15 as the number of patients going on for COVID has reduced. I think that in terms of the structural problems that are there, that low volume and heterogeneity, both in pediatric critical illness as well as in ECMO, makes it harder for us to generate evidence. And then the low volume and heterogeneity makes it less likely that the child design devices will be available for our critically ill children. And so this is just looking at some of the evidence generation that we see in adults in the last 10 years. So within ECMO, there have been 30, here in gray is the per year, 30 clinical trials done in ECMO, whereas in about 3,000 total patients enrolled per year. Over those 10 years. Whereas in pediatrics, we've seen 1 not registered pilot clinical trial of 31 patients published in the literature. There are ongoing unpublished clinical trials. This one is called TITRE, which is trying to better understand the transfusion that we should be doing, that we here at the University of Michigan are participating in. And this is about platelet transfusion. It's a pilot study that's hopefully going to generate some evidence to power a better clinical trial in the space. But nonetheless, the difference is quite stark, 30 versus 1, and 30 patients versus almost 3,000. I think if you look beyond ECMO into the sepsis and ARDS literature, I find this to be 2, well, a little bit dated illustrative examples that I think we can learn too. So this is these sepsis clinical trials, all published in the New England Journal of Medicine, were around a type of therapy called early goal-directed therapy. The approach to that is less important than the findings, which were published in 3 separate clinical trials. And then a planned meta-analysis that aggregated all of that information done just 3 years after the first. And this similarly was done in looking at an ARDS strategy of care using an oscillator, which is similar to a strategy of ventilation that's being used in Prospect. And once again, just 3 years after a clinical trial, those clinical trials, a systematic review published. And so I'll come back to what I think is the things that we should borrow from that. But first, I want to talk about what we're doing in the same space right now in pediatrics. And so this is prompt bolus is looking in patients that have sepsis, how we should fluid resuscitate them. This work is being led locally by one of our own, Dr. Gorga. And it is seated in 3 different networks, research networks that help to support the infrastructure of it. Locally here in the US is PCARN, in Canada is PERC, and in the Australia, New Zealand, or ANZICS area is PREDICT. Each of those kind of infrastructures support the study slightly as well in terms of funding, but the primary source of funding is one grant supported by the NIH. I think also interesting and important to emphasize here is the consent strategy that's done in these critically ill children. So it's really hard to approach critically ill children and their families and talk to them about doing research, which probably does systematically contribute to the lack of their participation in research in a way that's probably not aligned with people's goals. But they have gotten around this with EFIC, which is an emergency exemption for informed consent in the US, and then in Canada and Australia, they use a deferred consent strategy, which isn't available to us in the US. Prospect is a kind of more typical clinical trial, which is very large in its scope. There's over 50 sites that span the US, South America, Europe, Asia, and Australia. But it has a kind of centralized approach to infrastructure, and unfortunately, also a typical approach to consent that has led to delayed enrollment. And so it's currently at 307 patients, about 5 years after it started enrollment. And so I think what the sepsis studies showed us in particular is an alternative way of doing this potentially that distributes ideas and risk. And so Derek Angus, who led the process trial, the first of those sepsis clinical trials that was published, Once he wrote that grant and submitted it to the NIH for funding, he then shared that grant with those other sites, and they applied for and were granted funding separately and individually, and then separately and individually were able to publish their findings. And I think that kind of independent distributed infrastructure is something that we should think about and potentially learn from within our own community. And I think that when I talked to Scott Weiss, who's leading Prompt Bolus, about how he was doing this and what he was doing with it, his comment was really that I just didn't feel like we could power the study individually across those networks to a primary outcome of interest. And while I didn't push back on Scott about this at the time, I think I would if he was here, is just think with him about, I think, some of the things here in terms of early goal-directed therapy. What the primary outcome that they looked at was mortality, and that's the outcome that most of us are going to care about. But they were able to then, in these planned meta-analysis, look at some of these secondary outcomes of interest in terms of and show some of the harms that were a part of early goal-directed therapy, which is that there was longer associated ICU stays, longer cardiovascular support use, and higher average costs. In pediatrics, though, in general, our mortalities are much lower. In Scott Weiss's study of epidemiology, he estimated it to be about 25%, but it varies quite a bit depending on the severity of illness. And I think there's opportunities potentially to really focus on the things that families say are the most important to them and provide much more linear measures of outcome in terms of health-related quality of life, functional status, organ dysfunction duration, and post-hospital development that we could primarily power to, and then look at aggregated samples for some of those more dichotomous outcomes that are important, such as mortality, and planned systematic reviews and meta-analyses at a patient level. Unfortunately, and this is coming back to your question, in terms of devices, our life-threateningly ill kids are really relied systematically to rely on tools that are designed for others. And the reason for that is a bunch of things, but we haven't been able to fix it so far. And so legislative, regulatory, and scientific efforts have failed to make pediatric medical devices available to children. And as a consequence, adult devices approved for adults are then applied off-label to children, exposing them to at least unevaluated, if not higher risk, and then probably deepening the health inequities of children. And so the FDA, specifically the Center for Devices and Radiologic Health, which is where devices are cleared, look to be evaluated for clearance, point to persistent lack of availability of access to medical devices for children. And so this is some of their internal data. And basically, if you look at adults, it's 2 times faster. This is this green bar here than when we look at all pediatrics. But when we look at devices that are cleared specifically for children, it's 21 times faster. But 88% of those adult cleared devices could treat similar diseases or conditions in children. And the consequence in ECMO is really that every center designs their own specific approach to the configuration of the ECMO circuit. And so these are just a handful of various different approaches that are designed to be able to overcome some of these things within the pediatric ECMO space. And that probably impacts some of those adverse events that we were talking about earlier, and I'll come back to in a bit. But in reality, I think in order for this to move forward, it is going to take government action, and that's exactly what's happening right now. And so the FNIH, which is the Foundation for National Institutes of Health, which was established by Congress in 1990, is an independent organization that really seeks to bring together the NIH, academia, life science companies, patient advocacy groups, and then partnership to advance breakthroughs where things are getting stuck. And so a current FNIH project is a pediatric medical device public-private partnership that's ongoing right now. It's smack in the middle of the design phase, which is an 18-month period from 2023 to 2025. That's bringing really members of every institute of the NIH together, as well as members of BARDA and DARPA, the FDA, and other governmental agencies, along with device developers, to help to think about how we can do this better. There are 6 integrated streams, which I'll show you on the next slide. And then the project strives to develop a sustained infrastructure for successful development of commercialization of these devices. And so this phase right here is where we're at. Hopefully this will result in an executable project over the next that lasts for 5 years, and then a sustainability phase beyond that. And these are those streams that I was talking about. And so where I'm working is really within this regulatory stream right here, which is got a short-term goal of facilitating and increasing the use of existing programs and pathways to support pediatric medical device development, approval, and clearance. The reason that I've had the opportunity to do this is we've also previously leveraged the ELSO registry to use real-world evidence to look at clearance of devices for both children and adults with successful applications in both of those. And then in the medium term and long term, think about new programs and new legislation. And then just actually in a month, we'll be in Baltimore to work on putting together a initial research outline for a white paper. It's exciting, but also the device space really is quite consequential. And so recently, between 2018 and 2019, we lost a pediatric dual lumen cannula that helped us avoid placing cannulas in the carotid artery. And with the loss of that cannula, we saw a 20% increase in the use of cannulation of the carotid artery. And then there was a replacement of a new cannula that then has seen those go down by 10%, hopefully reduced back to where we saw before. But Dr. Coney is working to use the ELSO registry data to see what this might be costing patients in terms of new strokes, just due to the loss of this cannula. And so I think what all of this shows in terms of thinking about device access really is that the fragility of access and the lack of pediatric design devices may be one of the contributing factors in terms of why these adverse event rates are so much higher in our children as compared to our adults, recognizing that, of course, this is multifactorial, both in terms of the pathophysiology of disease and the capacity to screen patients. So I tell Jane's family that maybe we can do this better, both in terms of our evidence generation and in terms of working with government and device developers to find new paths forward. And so a potential future path forward as it relates to ECMO, I think is, right now we have seen, if we look across the lifespan of the ELSO registry, that really survival has not improved since 1989. Now, a bit of this is the changing population that's receiving ECMO, but if we were to put up a similar strategy for patients who have cancer, the graphic would look much different. And so I think that one of the important paths forward is elimination of unnecessary heterogeneity. This work from Karen just says that variation is a symptom of major evidence gaps regarding best practices, and then follow-up work talking about that they also serve as targets to improve care and outcomes of hospitalized children. We know within the anticoagulation practice of children which are on ECMO that there is persistent enormous variation in the way that we do that from center to center. But there is organization underway, which I think is a necessary first step to reduce some of that harmful heterogeneity. So first is just speaking the same language. So already published has been a nomenclature in 2018. And what I'll show you on the next few slides is some work that we've done in terms of adverse events. And then next is also a common recipe. So thinking about anticoagulation done similarly across centers, and then a common tool, which is what I think could be the potential intervention for a clinical trial that I'll set up briefly before I finish. And so in terms of the Academic Research Consortium ECMO Central, it was a project really, as the kind of title suggests, to create core elements needed for trials, regulation, and quality of life. Academic Research Consortium was not something I was familiar with before the FDA asked us to develop these definitions, but it's a board that includes members from the FDA as well as scientists, primarily interventional cardiologists worldwide, that developed this because they were needing to clear adult cardiac interventional products. And they wanted to be able to test those products using common adverse event definitions across their clinical trials. And so the FDA asked that we partner to do this, as another group was doing this in the pediatric MCS space, and we launched and harmonized ECMO Central to that process. This is just a picture of some of us doing that work together. There ended up being about 165 of us that met across 4 3-hour-long meetings to help to work on these definitions. Oh, going the wrong way. The goal was to develop harmonized ECMO adverse event definitions for those clinical trials and regulatory evaluation. And the hope was that using these standardized definitions would facilitate systematic aggregation across clinical trials and regulatory device evaluation. The approach is summarized here, but largely we met with stakeholders to kind of and methodology leaders to develop an approach, put together an expert panel, ask topic experts to define those, and then to present those to our panel, receive feedback, and then they drafted definitions that were then sent out for review. Across the way, we were able to gain the endorsement of 12 professional societies shown here for the process and definitions. In terms of the adverse events that were defined, they're listed here. And actually, we were fortunate enough yesterday to gain acceptance for this publication. So hopefully that'll be out in a short while. I mentioned a common recipe, and so anticoagulation algorithms, both heparin and direct thrombin inhibitors, primarily bivalve, have also recently, of course, don't mean for you to read these, been developed as well. And so PEACE, which is a consensus program funded through an R13, developed this heparin-based approach, and then the Action Network, which is a mechanical circulatory support group that uses BADs or ventricular assist devices, which are have some similarities to ECMO, have developed a bivalve related one that is being used at a lot of centers right now. But what's left is addressing that common tool of the ECMO circuit. And so our goal is really to take a stakeholder-driven consensus approach to circuit design, hopefully to come up with a streamlined circuit designed for children that may help us to reduce some of those adverse events and build a common foundation for future science. And so, as I mentioned before, every center has its own different approach to this, and that creates problems. So recently, another device was taken off the market. That device was made by Getinga, and it's called the pediatric quadrux lung. It had about 90% penetration within the market. And so all of these centers had to change and shift what they were doing suddenly. And as they adapted, they created complications. And as they tried to fix those complications, they reached out to their peers to ask, how can we do this better? And realized that, in fact, their stuff was very different from center to center, and maybe the approaches couldn't be shared so well. What we do know, though, is that 80% of circuit formation of clot happens around connectors and these devices that are part often of adapting adult design devices to children. And so you can see some of that clot formation here. That then embolizes both to devices, causing failure to patients, causing stroke and other ischemic injury, as well as serves as a signal to bedside providers to increase anticoagulation, potentially leading to bleeding, intracranial hemorrhage, and transfusion, all leading to potential declines in functional status, organ failure, and death. And so right now, a group of us, myself, Dr. Alexander from Boston Children's, and Dr. Chris Horvath, a bioinformatician from UPMC, are working together to design this best pediatric circuit with key stakeholders, and then hopefully use a step wedge clinical randomized trial to do a pragmatic clinical comparison between center's own device and our newly designed device, and also leveraging some of the bioinformatics work that Chris has done, hopefully, so that we don't have to have folks collect that information, but rather can pull it directly from the electronic health record and our streaming data collection. We use for our primary outcome those same ECMO Central definitions that we put together in a composite format. And hopefully these will push us forward into a new age where while ECMO provides a possible window into the fact that increasing doses of critical illness may worsen mortality, adverse events, and post-intensive care syndrome, that we have a path to better understanding where those interventions are, and that while there are substantial barriers to us generating evidence and devices for children, that I think that there are potential mechanisms that have been illustrated in the adult space, as well as are being pursued right now with governmental cooperation to find better strategies for kids. And that hopefully the elimination of unnecessary heterogeneity will put us at a precipice that I believe will facilitate a better future.
That is all I have.